بسم الله الرحمن الرحيم. Today we will have case quiz number 90. Case data: 45 years old female complaining of progressive upper and lower extremity proximal weakness of a few weeks duration. 3 months prior to this condition, the patient was diagnosed as systemic lupus erythematosus and started on hydroxychloroquine, and low-dose prednisolone was added for her weakness for the last 3 weeks. Examination: severe proximal weakness, grade 2/5, in bilateral upper and lower extremities with retained strength in all other muscle groups. Erythematous rash on face, chest, and upper back, and no clinical evidence of involvement of other organs. Investigations showed creatinine kinase over 50,000 units per liter. So creatine kinase is shooting 50,000 units per liter. CT scan of the chest, abdomen, pelvis revealed no evidence of malignancy or interstitial lung disease. ANA was positive by immunofluorescence with a titer 1/80. Negative ENA and anti-double-stranded DNA, but positive anti-PL-7 and anti-Mi2. The rest of myositis-specific and associated antibodies were negative, including anti-TIF1 beta, anti-MDA5, anti-NXP2, anti-SAE1, anti-JO1, anti-BL12, anti-EJ, and anti-OJ. Muscle biopsy of the left vastus lateralis was done. Hematoxylin, phenixylin, saffron stained sections show markedly abnormal muscle with numerous atrophic, necrotic, and regenerating fibers in a striking perifascicular distribution in figure 1 and figure 2. There was fragmentation of biremesial connective tissue with infiltration by histiocyte, as we see in figure 3, and alkaline phosphatase staining in the biremesium, as we see in figure 4. Immunohistochemistry for MHC class 1 showed upregulation of the sacrolemma of all fibers with slight perifascicular accentuation, which is seen in figure 5. Staining for C5b-9 membrane attack complex, or MAC, showed intense deposition of the sacrolemma of non-necrotic fibers in a predominantly perifascicular distribution, but not on capillaries, as we see in figure 6. Follow-up of this patient: prednisolone was continued together with methotrexate, and intravenous immunoglobulin was added. At follow-up 1 month later, she showed clinical improvement of proximal muscle strength to from 4- to 4 bilateral upper and lower extremities, and the CK creatine kinase decreased to only 1,169 units per liter. So, what is the diagnosis? The answer is, take a while and think. You can stop the video here, and if you want the answer is anti-synthetase syndrome associated myositis. Anti-synthetase syndrome associated myositis. Discussion of the diagnosis. Myositis is a characteristic feature of anti-synthetase syndrome, ASS, along with interstitial lung disease, arthritis, Raynaud's phenomenon, mechanic's hand, and the presence of serum anti-aminoacyl tRNA synthetase antibodies. ASS-associated myositis has characteristic morphological features that distinguish it from other inflammatory myopathies. As in our case, muscle biopsies show striking perimysial and perifascicular distribution of pathology, with perifascicular fiber necrosis, regeneration, upregulation of MHC, and sacroilimbal deposition of MAC. The perimysium show fragmentation, inflammatory infiltrates, and alkaline phosphatase staining. The differential diagnoses include dermatomyositis, but perifascicular necrosis, as opposed to atrophy, is a relatively specific feature of ASS-associated myositis. Clinical, serological, pathological correlation is essential in the diagnosis of inflammatory myopathies. Our patient presented with weakness and rash and had positive serology for both anti-PL-7, anti-threonine tRNA synthetase, and anti-Mi2 dermatomyositis specific antibodies. While the muscle biopsy results were consistent with the presence of anti-PL antibodies, there were no other clinical features of ASS. Interestingly, the patient's clinical presentation was more suggestive of classic dermatomyositis and consistent with positive serology for anti-Mi2 antibodies. Anti-Mi2 is associated with classic skin findings of heliotropic rash, Guttron babule, and V and Shaul signs, rash on chest and upper back respectively. Typically, muscle biopsy show classic pathological findings of perifascicular atrophy and perivascular inflammation. Due to the somewhat discordant clinical, serological, pathological features of this case, the clinical course of this patient is difficult to predict. Anti-Mi2 is associated with good response to therapy and low risk of interstitial lung disease. In contrast, anti-PL-7 is commonly associated with inflammatory lung disease, which increase the risk for morbidity and even mortality. Our case therefore highlights the importance of a robust serological workup, having low threshold for muscle biopsy, close clinical follow-up, and careful clinical, serological, pathological correlation in inflammatory myopathies. And finally, thank you very much for your attendance, and we will meet you tomorrow with case quiz number 91. Wassalamu alaikum wa rahmatullahi wa barakatuh.